even though healthcare is so complex, sometimes very simple, common sense practice can have a significant effect, even on the most complex of systems.
Hello, welcome to Delve, the official thought leadership podcast of the Desautels Faculty of Management at McGill University. I'm Sabine Dhir, Assistant Professor of Strategy and Organization here at the Desautels Faculty of Management, and I'm your host today. If you're plugged into the worlds of healthcare, international development, or foreign aid, you'll know that to make an impact, you need to maximize your dollars. You want to make sure that every cent goes towards helping people, some of whom are the most vulnerable on the planet, and you want to do it as efficiently as possible. But in many contexts, that's easier said than done. In the Democratic Republic of Congo, for instance, foreign aid has been instrumental in lowering infant mortality rates. But it's clear we still have a long way to go. Our guest today is Professor Anicet Fangwa, a colleague of mine here in Strategy and Organization at Desautels. In a recent study, he identified and tested 3 management tactics for boosting healthcare efficiency in the DRC, and the results have been remarkable. And his findings aren't just useful for healthcare. These tools could help any impact-driven organization improve their performance and support their communities. Professor Fangwa joins us now. Let's delve into it. Anicet, it is such a pleasure to talk to you today about this incredible body of work that you've recently published and that touches on so many things. I think anyone who's paying attention to healthcare, not-for-profit governance, and developing nations would find incredibly compelling. Not just people interested in that, but anyone who's interested in how it is we can do a better job supporting communities and countries that are looking for support, especially when it comes to healthcare.
Thank you. Thank you very much for having me, Sabine.
Can you provide an overview of the current state of healthcare systems in low-income countries like the DRC?
The main challenges, not just for DRC, but like overall the developing world, is basically, first of all, the quality and the quantity of the health workforce. So basically, there's a lack of people trained in nursing, in all the different arrays of the medical specialties, and in DRC in particular, there's a severe lack of specialists. Second of all, there's limited funding. For example, healthcare represented less than 10% of the DRC budget annually. And I think the last figure that I have in mind is actually 3% in 2017. Money that came directly from the government towards healthcare. And because of that, there's a lot of institutional donors like USAID, like the World Bank, Cordate, which actually have to step in to actually fund the health system in general. So there's a severe lack of funding. And finally, the lack of organizational knowledge, like managerial knowledge, how to run the organization efficiently. One of the main things that I have seen is difficulties to manage the stocks of drugs, difficulty to manage the finances, and there's a lot of issue with fraud and the inability to actually track the money from the beginning to the end. And it severely affects the ability of the organization to perform well.
So keeping that in mind, what has been the traditional approach to funding healthcare improvements in these regions? And if you can, what are some of the criticisms of these methods?
There have been different approach. The first one was to be able to train people locally. Mm-hmm. Basically, take locals, have them train outside of the country and bring them back inside the country. But that approach makes that when they get out of the country, they were exposed to disease and specialty that are not necessarily relevant to their local reality. And they when they came back, they felt a sense of disconnect from what they have been trained to do and what they actually have to do on the ground. Mm-hmm. The second approach was to actually give a lot of money. And this is basically what have been done up until 2009, because in 2009, it is where they actually implemented, and it was implemented the first time in Southeast Asia, performance-based financing. Basically, not only dumping money on the service and say, okay, this is the money, do whatever you want, but actually we are going to give you money only based on the fact that you reach a certain level of objective, either in terms of quantity or in terms of quality. And that kind of helped revolutionize the way aid has been implemented in the developing world in general. But before that, it was just dumping money. And unfortunately, sometimes money in form of debt, meaning that not only they are not able to use it efficiently to actually improve the health outcome, but they haven't developed the capability to actually give that money back.
So let's talk about the project then. So the World Bank developed a project that addressed governance and healthcare systems. And I'm going to ask you now to describe what is referred to as the Health System Strengthening for Better Maternal and Child Health Project, or the Projet de Développement des Systèmes de Santé, or the PDSS.
The PDSS, the objective is to improve the quality of the services delivered to mothers and children in DRC. It is a nationwide program, and the idea is to directly support a health facility that have been pre-selected because they had like the minimum requirement to actually participate in the program. And they basically, right from the beginning, received this lump sum of money to actually set up better equipment for them to be able to deliver high quality services. And then from that, they were provided the guidelines about how to do each and every single medical act that they need to respect. And they were funded based on this performance-based funding mechanism in which you need to achieve a certain level of quantity of service to actually get paid. And finally, there was these teams of experts which were trained by the World Bank and which were charged to actually go into those facilities to actually make sure and audit and give them some feedback. The period of time that we have been observing that program, it has very strong and significant results.
Okay, so this particular program, the PDSS, relied on performance-based incentives, and it also relied on auditing and feedback. And these are two management tools that really, from what your work showed, helped improve healthcare delivery for those clinics and centers that were a part of this PDSS project. What do those tools look like in practice?
In practice, it was huge books, basically, registers, because for every single medical act that they had to perform, they were tasked to actually write it down. So the first principle of that program was transparency. So whenever a patient arrived, his name was written down in the register. The person who served him was written down. The service that he received, the number of drugs, and all the attention and service that he received were selected and written down in the register. After that, when at the end of the quarter, when the expert team will arrive, they will actually go through all the registers to make sure that the declared quantity of service is actually found in the register. And they will even go further because they will select like 3% of those people which are said to have received a service and go into the village, go into the city to find those people and check with them how well, and not only how if they received the service, but also what were the appreciation of the service. Was it well done? Where they were treated?
This sounds like a very thorough auditing process. And at some level, something, you described that collection of information, something that, in some places we would consider relatively standard. But this seems quite novel.
No, it was revolutionary. Basically, because they had to put in place those registers.
Okay.
People were not using them.
Okay.
And they also had this very interesting reporting system to actually digitalize those information and put them into what they have called, in French, it is Système National d'Information Sanitaire. SNIS, in which you can actually on a day-to-day basis go and check what level of performance has been reached by each and every single health facility. It was the first time in the country to have those type of technology.
So that's the auditing part of auditing and feedback.
Yes.
What's the feedback part?
The feedback part is basically the fact that once they come and see how the register has been maintained, they are able to help them do better. But also, it's not about medical training. It's really about governance and organization. So like the hygiene, the routine that they put in place, all the different managerial practice that they need. This is what the feedback is about.
So your work very much proposes that by bundling this performance-based funding approach with the auditing and feedback makes sense.
Yep.
Right. So what's the rationale behind that approach?
Yeah, the rationale behind that is what we call learning complementarity. It's basically the fact that once you have learned a skill, it's easier for you to learn the adjacent skill. And when you have both of them, you can do better. In this particular case, they learn not only how to better manage the organization, but they also receive extra money that motivates them to do better. So it's not only, we improve not only their ability to do, but also their willingness to do. And this is the complementarity that leads to higher performance. So that's also why there was a need for audit, but also feedback. Yeah.
Audit, feedback,
and incentives.
And incentive.
Yeah.
Performance-based incentives. Okay, so the combination of all three is what's required to have a significant impact.
Yes, and this is exactly what we find in the paper. We see that we can reduce the probability of infant mortality by almost 25% just by implementing those governance mechanisms.
Wow. So an increase, 25% difference, nothing to do with the medical training of the nurses and doctors, but everything to do with just implementation of governance and management practices. One of the things I also wanted to highlight is, in addition to sort of the hard data that you pull from your study, which really just beautifully shows the relationship between offering not just performance-based incentives, but this auditing and feedback component, you did spend time interviewing the program participants. And this highlighted something that, as you allude to, is sort of underrepresented, which is the importance of training. How did the feedback mechanism, according to those program participants, when you, in their own words, how did that feedback really help them with the training and organizational know-how?
The most significant feedback that I receive is basically to enable them to manage a budget. Just that, to be able to budget and to plan and to organize the needs into priorities was transformative. The reason why training is so important is because most of the time when you go into medical training, you are very focused on the knowledge to know the human body and all the different mechanisms that take place in somebody's body. But to look into how the organization will operate is a completely different set of skills. And for this particular type of health facilities, which are very small and do not necessarily have the huge administrative structure that we can see in the developed world, most of the time it is basically the head doctor who ended up managing, and he or she does not have the skills to actually budget, prioritize, plan, and make like those workflow that will enable the organization to work properly. And for them, it was that which was life-changing.
There's a level of optimism here to what you're saying, right? That these skills that seem to have a huge impact can be taught and can be incorporated. Talk to me a little bit about the latency from the time of this kind of project is implemented to the time you actually see the effects.
The learning here is actually not just memorizing something. It's really much a change in behavior.
Okay.
And that's why it takes so much time. It's because it's not just I know something. It's I know it and I change the way I do things. So basically, for example, one critical thing that they have put in place is when they take the patient, a pregnant woman, in before, and they just had to wait, and they can wait for the whole day to actually be received and then treated and sent back home. Mm-hmm. One of the things that they actually put in place is basically put in place not only a vehicle that can carry the woman from the village to the hospital, but also put in place, give them a free breakfast, which is normal, right? Mm-hmm. It's not such a big deal, but just giving them that breakfast that actually enable them to be less stressed, and be more confident and be more willing to take the medication, mm-hmm. take the vitamin, take all the different treatment that they need to have before going back and coming back for the next consultation. So all those little changes in not just in mindset, but also in how the operation is run, have a significant effect at the end of the day.
It's clear that what you're, it takes a year to learn and then almost another year, but in 2 years to have something like a 25% impact on infant mortality. And that's an incredibly short amount of time to have such a significant impact. And what you're talking about is a really complex system. Healthcare is complex. It doesn't matter where you are in the world, but especially so in a low-income developing nation. So, one of the things I have to ask you is, how do these findings of yours, how do they have broader implications and broader applications outside of, let's say, healthcare, or even, in terms of just governance practices in general?
So first of all, it gives us proof of the fact that we need to allocate some resource to the governance structure mm-hmm. of any intervention that we want to have, because all the money the funding that you provide to a particular cause need to actually be better managed to make sure that it generates the maximum impact. The second takeaway is learning takes time. It involves not just a change in the knowledge that you have, but mm-hmm. also it requires you to change the behavior and the priorities that mm-hmm. you have. And to come out of a particular behavior and set of routines to engage with a new one, it needs not just willingness and incentive, but also supervision. And the third takeaway, which can be generalized now, is the fact that even though healthcare is so complex, mm-hmm. sometimes very simple, common sense practice can have a significant effect even on the most complex of system. That's something that really blew my mind when we figured it out. Is like, okay, just having them writing down the names of the patient for traceability, or making sure they do not run out of drugs, enable them to save life at that level. And it gives us also a strong sense of hope, because when you look at the numbers and the evolution of infant mortality rate in those type of region, you see that they are quite stagnant at a very high level. But from this study, one of the key takeaway for me is basically that there's still some hope. And if we are able not only to replicate those type of program, but also to scale them. So if you're able to scale them at the nationwide level, we might be able to reach the SDG goals in time.
This sounds fascinating, Anicet. So the work finished in 2022, and I'm sure the project is still ongoing. And so what have you found since then? Basically,
the program has ended in 2022, having started in 2017. So 5 years of incentive, audit, feedback. And the question that we actually ask ourselves is, what happened when it stopped? How much of that knowledge, of that new behavior, and of that incentive the workforce will be able to retain once the money is gone? Because you will never have enough money to keep on funding all the project, right? And what are the factors that actually enable them to keep it longer or as long as possible? And we started collecting the data from 2017 to 2022, so within the program, and then 2023 to now. And we are quite optimistic to say that they were able to maintain a certain level of efficiency for the next 2 years after the end of the program. But one of the key question that we are investigating right now is the effect of diversity. So how diverse the workforce was in terms of gender diversity, but also in terms of educational diversity. Has it an effect on how well the organization was able to retain their level of efficiency after the interruption of the funding? It's a very critical question because, once again, you will never be able to fund all the project all the time. So you need to prioritize, and you need to interrupt some program to fund other program. And you need to be sure that once you have gives that significant amount of money to a particular project, you really do not want to know that once you have stopped, everything roll back.
So this is going to be some very interesting follow-up, and I can't wait to continue this conversation to see what comes out of this next phase. Thank you so much, Anicet. So I got so many great takeaways from this interview. With a few simple management practices, we can drastically improve healthcare for some of the most vulnerable populations in the planet. And I think that's not only useful, but incredibly hopeful. Thank you, Professor Fangwa, for your tremendous work and for sharing it with us today. And a special thanks to you, our listeners. Don't forget to subscribe to our show and leave a review. You can also subscribe to our newsletter. We'll send you our latest podcast episodes and other great thought leadership pieces. You can sign up at delve.mcgill.ca. My name is Sabine Dhir, and I was your host today. Eric Dicaire is McGill Delve's assistant editor. He produced and edited the show. Saku Mantere is McGill Delve's editor-in-chief, and he created all our original music. Thank you so much for listening. Until next time.